Welcome back to the Deep Dive, the place where we tackle, the most complex, dense stacks of source material.
The stuff you really need to master.
Exactly. And if you are attempting to map the microscopic world of the body's ultimate filtration system, you've come to the right place. Today, we're doing a deep dive into renal pathology.
Yeah, and our mission today is to really move beyond just rote memorization. We're going to look at the kidney as a three-part system.
Yeah.
You've got the filter, the tubing, and the outflow. And understanding how failures in each of those spots lead to, really specific, dramatic clinical syndrome.
So this is like a conceptual framework for triaging everything.
That's the goal. From glomerulonephritis to AKI down to, the bugs and stones causing obstruction.
I just find the complexity of the kidney so fascinating, especially how its tiny structural components, like a basement membrane, are so critical to your entire systemic health.
Oh, absolutely.
The source material even draws this interesting parallel, It suggests that the integrity you need for filtration is like the cellular anchors you need everywhere else.
Like in Duchenne muscular dystrophy.
Exactly. A single nucleotide deletion causes a frame shift, and poof, the dystrophin protein is gone, and that protein is what anchors muscle fibers.
And that's a powerful analogy because the kidney filter is just as precarious. The podocytes, those specialized cells,
The final anchor.
they are. They wrap their little foot processes around the glomerular basement membrane, the GBM. And if just one protein fails, if that anchor gives way, the whole barrier collapses.
And the consequences are profound.
Systemic.
We're exploring the kidney's crucial role in maintaining fluid and electrolyte balance. And when that fails, you see everything from life-threatening hypertension to, profound edema.
Yeah.
So let's set the stage. Let's dive right into the foundation of kidney pathology. The two major ways the glomerular filter fails.
We have to establish this right away. The filter fails in two fundamentally different ways, and they determine the entire clinical picture for the patient.
Okay.
The first failure is inflammatory and destructive, nephritic syndrome. The second is, it's purely one of integrity and leakage. That's nephrotic syndrome.
Okay, let's unpack nephritic syndrome first. What defines this? Is it like a battlefield inside the glomerulus?
It is exactly that. Nephritic syndrome is all about acute inflammation and just physical damage to the GBM.
And what's causing the damage?
It's often immune complex deposition or maybe a direct antibody attack. That kicks off complement, cellular proliferation, and ultimately a breach in the filter.
A physical tear.
A physical tear. And because the breaches are big enough, you get cellular components, huge red blood cells escaping into the urine.
So the key diagnostic sign is blood in the urine, but it's not just any blood. You're looking for specific clues that the damage is happening way up in the kidney.
Precisely. The core clinical presentation is hematuria. That's critical. And because those red blood cells are being squeezed through these tiny damaged holes,
They get all misshapen.
right, we call them dysmorphic RBCs. But even more definitive is the presence of red blood cell casts.
Which are basically molds of the tubules filled with blood.
Exactly. It confirms the bleeding is coming from inside the nephron. It's the smoking gun.
So what are the systemic consequences of all this inflammation?
Well, the inflammation itself just tanks the glomerular filtration rate, the GFR.
Okay.
So this reduced filtering leads directly to azotemia, the buildup of BUN and creatinine and oliguria, which is just low urine output.
And the hypertension.
Well, the kidney senses this low flow, so it cranks up the renin-angiotensin-aldosterone system. That, combined with fluid retention, gives you significant hypertension.
Got it. And protein is also lost, but not as much.
Right. There is some proteinuria, but it's generally mild, typically less than 3.5 grams per day.
Okay, so now let's pivot to nephrotic syndrome. If nephritic is the battleground, nephrotic feels more like a structural collapse.
That's a much better way to look at it, yeah.
The filter's selectivity is gone, but without all that rampant inflammation.
Exactly. Nephrotic syndrome results from damage or effacement of the caudicite foot processes. The physical pores aren't torn open, so cells don't get through, but that negative charge barrier and the filtration slits are compromised.
So the selective barrier just fails.
And you get a massive, indiscriminate leak of plasma proteins.
And the defining feature here, the thing you can't miss, is just the sheer volume of that protein loss.
Yes. The clinical definition is massive proteinuria, so that's greater than 3.5 grams per day.
Yeah.
And this leads to the fundamental systemic consequence, hypoalbuminemia,
You're losing albumin into the urine faster than the liver can even make it.
Exactly.
And that loss of albumin causes those really dramatic, visible symptoms, the widespread generalized edema, the oncotic pressure in the blood drops, and fluid just leaks out everywhere.
It does. But the consequences of losing other proteins are what makes this syndrome so clinically dangerous.
This is what you really need to understand.
This is where we connect the dots between a microscopic podocyte injury and, life-threatening systemic illness. When that filter leaks, it leaks a lot of things.
So what are the top 3 systemic risks linked to this protein loss?
Okay, first and foremost is the increased risk of thromboembolism.
Clots.
Big time. We lose our circulating anticoagulants, especially antithrombin III, which is a key regulator of the clotting cascade. The patient becomes hypercoagulable.
So they're at high risk for DVTs.
DVTs and classically renal vein thrombosis. This is a critical thing to manage.
It's such an interesting biological attempt to compensate, isn't it? The body's losing fluid, so the liver ramps up production, but it starts making the wrong things.
Exactly right. And that leads us to the second and third risks, hyperlipidemia and lipiduria.
Okay.
Because serum oncotic pressure is so low, the liver desperately tries to synthesize any protein to maintain it, including lipoproteins.
So it's just chaotic compensatory overdrive.
That's a perfect way to put it. And this overproduction of lipids, plus impaired clearance, leads to severe hyperlipidemia and those fatty cats in the urine. Another pathognomonic finding.
That distinction is so helpful. So nephritic, inflammation, blood, hypertension. Nephrotic, leakage, massive protein, edema, and a huge risk of clotting.
That's the core of it.
Now, what about the severe overlap condition, the one that signals imminent kidney failure?
That would be rapidly progressive glomerulonephritis, or RPGN, sometimes called crescentic glomerulonephritis.
And it's as bad as it sounds.
It is. It presents acutely, often with severe nephritic features, but it progresses to chronic kidney failure in weeks or months. It signals severe, uncontrolled damage.
So what does that crescent description actually tell us about what's happening?
Well, pathologically, the biopsy is.
Yeah.
It's devastating. The crescent is this accumulation inside Bowman's capsule. It's made of this aggressive cellular proliferation, parietal cells, monocytes, macrophages, all mixed up with fibrin and plasma proteins like C3b.
So it's physically obliterating the glomerulus.
It is. The prognosis is poor, and it requires immediate aggressive treatment.
Okay, moving beyond the syndromes, let's zoom in on the specific causes, the etiologies. This is where immunofluorescence, the IF staining comes in, right?
Right. We're essentially using the microscope to see who the attacker is and where they're depositing their weapons. And this categorization is key. We can look for linear deposits, granular deposits, or basically no deposits at all, which is pouchy immune.
Let's start with that classic linear pattern. That points us straight to Goodpasture syndrome.
Goodpasture is a classic type 2 hypersensitivity reaction. The patient is making autoantibodies, specifically IgG, that are targeting the alpha-3 chain of type Z collagen.
And that collagen isn't just in the kidney?
No, that's the crucial part. It's a fundamental component of the GBM, but it's also in the alveolar basement membrane in the lungs.
So the antibody attacks both the kidney and the lung, which makes the clinical picture instantly recognizable.
That's the critical piece of integration. The disease presents as a pulmonary renal syndrome. You get acute nephritic syndrome hematuria, dropping function, plus severe hemoptysis, lung bleeding.
And the IF finding is that striking linear pattern.
Exactly, because the IgG is just binding uniformly all along the GBM. If you see linear IF, you have to be thinking anti-GBM antibodies.
Okay, now let's jump to the opposite extreme. RPGN, where the biopsy is almost blank. You mentioned pouchy immune.
Right, so if you see RPGN, that rapid kidney destruction, but the IF shows little or no significant deposition of immune complexes or complement, we call it pouchy immune.
Which tells us the damage isn't coming from stuff getting stuck in the glomerulus itself.
Exactly. The ghost isn't in the glomerulus. The damage is driven by circulating autoantibodies that target components inside neutrophils. These are the ANCA-associated vasculites.
Anti-neutrophil cytoplasmic antibody.
Yep, ANCA. They activate these white blood cells, which then go on to damage small vessels all over the body, including in the kidney.
And we break ANCA down into the 2 most critical types, right?
Yes, the two high-yield ones. First, you have PR3-ANCA, or CANCA, which is strongly associated with granulomatosis with polyangiitis, or GPA.
Right.
And second is MPO-ANCA, or PANTA, which is associated with microscopic polyangiitis.
And what's the difference in presentation?
Well, both cause this severe destructive vasculitis in the kidneys, but GPA also classically involves the upper respiratory tract and lungs. Microscopic polyangiitis is generally more limited to the small vessels in the lungs and kidneys.
That's a great framework. Okay, let's shift back to the protein-losing diseases. Let's start with the most common cause of nephrotic syndrome in adults, membranous nephropathy.
Membranous accounts for a huge portion of adult nephrotic syndrome. Pathologically, what's happening is immune complex deposition in the subepithelial space between the podocyte and the GBM.
And that deposition injures the podocytes.
Right. It triggers complement activation, injures the podocytes, and leads to massive protein loss. On microscopy, this gives you that classic spike and dome appearance on a silver stain.
And this disease is heavily linked to secondary causes, isn't it?
It is. About 75% of cases are primary, often linked to autoantibodies against phospholipase A2 receptor, or PLA2R.
But you always have to rule out other things.
Always. The secondary causes are vast. Infections like Hep B or C, syphilis, autoimmune conditions like lupus, common drugs like NSAIDs, and you absolutely have to screen for underlying solid tumors.
And linking back to our first section, this is the classic disease with that critical thromboembolism risk.
Absolutely. The chronic severe loss of antithrombin III makes membranous nephropathy a highly prothrombotic state. Renal vein thrombosis is a devastating complication here.
Okay, next up. Focal segmental glomerulosclerosis, FSGS. This one can be even more aggressive.
Yeah, FSGS is characterized by sclerosis, which is scarring in some but not all glomeruli. That's the focal part. And it only affects part of those glomeruli. That's the segmental part.
And it's clinically aggressive.
Very. It can rapidly progress to end-stage renal disease. Microscopically, the key finding is effacement of the podocyte foot processes, but with that added element of segmental scarring.
And it has some very important demographic and systemic associations.
It does. It's noted to be more common in Black individuals. And importantly, FSGS can be secondary to conditions that put a huge strain on the filtration unit.
Like what?
High-yield secondary causes include HIV infection, chronic adaptive changes from obesity, and sickle cell disease. Identifying that secondary cause is vital.
And finally, we have to tie this all back to the most common systemic causes of glomerular damage, which are diabetes and lupus.
Yeah, diabetic nephropathy is, globally, the #1 cause of end-stage renal disease.
And what's the mechanism?
It's chronic hyperglycemia, leading to advanced glycation end products, AGEs, that deposit in the mesangium. This causes a mesangial expansion and those classic nodular scars called Kimmel-Steele-Wilson lesions.
And for lupus?
SLE is a classic type 3 hypersensitivity. You have circulating antigen-antibody complexes that deposit in the glomeruli. And lupus nephritis can present in a whole bunch of different patterns, which really dictates the prognosis and treatment.
Okay, let's shift gears from chronic disease to acute kidney injury, or AKI, a sudden, sharp decline in function.
And the whole clinical challenge here is rapid triage. We classify AKI by location. Prerenal, which is a flow problem, intrinsic, a tissue damage problem, or postrenal, a plumbing obstruction.
And triage is everything because the treatment for poor flow is to give fluids while the treatment for tissue damage is supportive care.
Exactly. And the high-yield urine labs act as the ultimate physiological readout to distinguish these.
So how does that work?
Well, let's start with prerenal azotemia. This is always caused by decreased renal blood flow, RBF.
So dehydration, shock, heart failure.
Any of those. The key here is that the kidney tissue itself is intact. It functions perfectly to conserve water and salt in response to that low flow.
So when RBF drops, the kidney thinks, oh no, I must be dehydrated, and goes into conservation mode.
Precisely. It maximizes conservation. It aggressively increases reabsorption of sodium, water, and urea.
And that gives us our diagnostic findings.
Exactly. The urine will be extremely concentrated, so urine osmolality will be greater than 500. It's aggressively retaining sodium, so urine sodium is low, less than 20.
And the gold standard, the EMA, why does that number drop so low?
The fractional excretion of sodium, FeNA, is the definitive measure of tubular function. It's the percentage of filtered sodium that actually gets excreted. In prerenal AKI, the tubules are working so hard to reabsorb sodium that FANA just plummets to less than 1%.
And the BUN to creatinine ratio.
Also high, greater than 20, because the passive reabsorption of urea follows that massive reabsorption of water.
So now, contrast that with intrinsic AKI, where the tissue is damaged and that capacity for compensation is just gone.
Right. Intrinsic AKI means the kidney itself is broken, and the most common cause is acute tubular necrosis, ATN.
So the tubules, the engines of reabsorption, are non-functional.
That's the diagnostic key. They can't follow the dehydration signal. They can't reabsorb sodium or water, no matter how desperately the body needs it.
So the UN findings just flip completely.
Completely. The kidney is salt wasting, and it can't concentrate urine. Urine osmolality drops below 350. Urine sodium shoots up above 40, and the FeNA is now greater than 2%, indicating significant sodium wasting.
And the BUN to creatinine ratio drops.
Right, to less than 15, because urea is no longer being efficiently reabsorbed.
So what are the key microscopic findings that just scream ATN?
The presence of muddy brown granular casts.
Okay.
These casts are just sloughed, necrotic tubular cells that clump together. Their presence confirms damage to the epithelium.
And the cause of...
Two big categories. Ischemia, prolonged shock, and nephrotoxins, like aminoglycosides, cisplatin, or IV contrast.
Beyond ATN, another critical intrinsic cause is acute interstitial nephritis, AIN. This is less about necrosis and more about an allergic response, right?
Yeah, AIN is a type 5V hypersensitivity reaction. It's inflammation of the interstitium, often triggered when a drug acts as a hapten.
And the list of culprits is long and full of common drugs.
Very common drugs. Penicillin derivatives, NSAIDs, PPIs, diuretics, sulfa drugs. The critical diagnostic finding for AI is pyuria, but with a specific type of white cell. Eosinophils in the urine.
Often with a fever and a rash.
Classically, yes.
Okay, finally, we have postrenal azotemia, the obstruction problem.
This is the easiest to conceptualize. It's just a block in the plumbing somewhere. Crucially, though, to cause AKI, the obstruction must be bilateral.
Or affect the only working kidney.
Or affect the only working kidney, right? Think renal stones, BPH, or neoplasms. The urine labs can vary widely here, so imaging, usually an ultrasound, is what you need to confirm it.
Okay, now we move entirely out of the filter and deep into the plumbing. We're talking microbial intruders and crystallization calamities.
Starting with infections. UTIs are common, but when they ascend and cause pyelonephritis infection of the kidney itself, they become really serious, and the cost of agents are essential to know.
Let's do the top 3 high-yield microbes.
Number 1, the champion, E. coli. Overwhelmingly the most common cause of all UTIs. Number 2, in specific populations, you have to remember Staphylococcus saprophyticus. It's the second leading cause, particularly in young sexually active females.
And number 3, the one that links directly to a type of kidney stone.
That would be Proteus mirabilis. It's notorious because it produces the enzyme urease.
And urease makes the urine alkaline.
Exactly. It hydrolyzes urea into ammonia, which jacks up the urine pH. And that alkaline environment is the perfect chemical soup for the formation of struvite stones.
Which are those huge staghorn calculi.
Yep, they can fill the entire renal pelvis.
Okay, switching to the other major plumbing problem. Kidney stones or nephrolithiasis? We have to start with the most common type. Calcium stones.
Absolutely. Calcium stones, mostly calcium oxalate, account for about 75% of all kidney stones. They're radiopaque, so you see them clearly on an X-ray.
What are the main risk factors?
The main one is hypercalciuria, high calcium in the urine, even if serum calcium is normal. Other big ones are high dietary oxalate, low urine volume, and critically, hypositraturia. Right. Citrate normally binds to calcium and keeps it soluble. If citrate is low, calcium's free to crystallize.
And the management is interesting.
It is. You increase fluids, use a low-sodium diet, and paradoxically, you use thiazide diuretics because they increase calcium reabsorption back into the blood, which lowers the urine calcium.
That's a great therapeutic link. Okay, now let's cover the other 2 high-yield stones, cysteine and uric acid.
Cysteine stones are unique because they're fundamentally genetic. It's an autosomal recessive condition called cystinuria.
A transporter problem in the PCT.
Exactly. A failure to reabsorb certain amino acids. And there's a mnemonic for those.
Thiolate.
Thiolate. Cysteine, ornithine, lysine, and arginine. Cysteine is poorly soluble, so it crystallizes, forming these very distinct hexagonal-shaped stones.
And finally, uric acid stones. These are often related to hypermetabolic states.
Yeah, strongly associated with hyperuricemia, like in gout, or high cell turnover states, like leukemia during chemotherapy.
And the key diagnostic detail.
They are radiolucent. You won't see them on a plain X-ray. You need a CT or an ultrasound, and you manage them with urine alkalinization and allopurinol.
To wrap up this section, let's hit two critical anatomical problems, ADPKD and Wilms tumor.
Autosomal dominant polycystic kidney disease, ADPKD, is a progressive genetic disorder. You get numerous fluid-filled cysts that gradually replace all the functional kidney tissue.
And the systemic reach of this disease is profound.
It is. The key complications, besides the obvious CKD and hypertension, are barrianeurysms in the circle of Willis.
Which carry a high risk of subarachnoid hemorrhage.
For sure. Also, benign hepatic cysts and mitral valve prolapse.
And then there's the malignancy of early childhood, Wilms tumor.
Like nephroblastoma, most common renal malignancy in early childhood, typically between ages 2 and 4. It usually presents as a big, palpable unilateral flank mass.
And there's a strong genetic link.
Yes, associated with loss of function mutations in the tumor suppressor genes WT1 or WT2 on chromosome 11.
Okay, we finish our deep dive by integrating the pathology with the pharmacology. Let's talk diuretics.
Yeah, and understanding where these drugs act on the nephron map dictates everything about them, their side effects, their uses, and their critical interactions.
All right, let's trace the flow, starting in the proximal convoluted tubule, the PCT.
Okay, in the PCT we have mannitol, an osmotic diuretic, and acetazolamide, a carbonic anhydrase inhibitor.
Which is why acetazolamide can cause a metabolic acidosis.
Exactly. Moving on to the engine room, the thick ascending limb of the loop of Henle, home of the loop diuretics.
Like furosemide. These are the most powerful.
They are. They inhibit that crucial Nevro plus K plus 2Cl cotransporter. By inhibiting it, you just abolish the kidney's ability to concentrate urine. They're vital for acute volume overload.
And they're infamous for their electrolyte wasting. Why, mechanistically, do they cause hypocalcemia?
Ah, that's a great connection. The transporter helps create a positive charge in the lumen, and that positive charge is what drives the passive reabsorption of calcium and magnesium.
So when you block the transporter...
You lose the positive charge, and you start wasting calcium and magnesium in the urine.
Okay, next stop. The distal convoluted tubule, the DCT, the primary site for thiazide diuretics.
Thiazides, like chlorthalidone, inhibit the Na plus Cl cotransporter. They're less potent than loops, but their unique feature is they actually promote calcium reabsorption.
The calcium-sparing effect.
Right, which makes them useful for patients with hypercalciuria who get kidney stones.
Now for the Ferris triple hyperconnection for the side effects of thiazides, this is a classic.
It is. This is critical for recognizing a patient on a thiazide. They cause hyperglycemia, hyperlipidemia, and hyperuricemia.
Which means they can trigger gout flares.
They absolutely can. And of course, they also cause hypokalemia and hyponatremia.
Okay, finally we reach the end of the line, the collecting duct, the target of the K plus the sparing diuretics.
Here we have two classes. The aldosterone antagonists, like spironolactone, and the sodium channel blockers, like imiloride.
And spironolactone's role goes way beyond just electrolytes.
It does. As an aldosterone antagonist, it blocks the bad effects of RAAS activation. And we know from clinical trials that it provides a significant mortality benefit in patients with heart failure.
That pharmacology dive leads us perfectly to one of the most vital drug interactions, lithium toxicity.
Oh, this is a high-stakes scenario.
Hmm.
Lithium has a narrow therapeutic window, and it's almost exclusively cleared by the kidney.
And a big chunk of it is reabsorbed in the PCT, right alongside sodium.
Exactly. So if you put a patient on a drug that tells the kidney, hey, we're volume depleted, reabsorb more sodium.
The kidney inadvertently reabsorbs more lithium along with it.
And you get toxicity. The main offenders every learner must know are thiazides, ACE inhibitors, and NSAIDs. Recognizing this can save a life.
So let's integrate this into overall management, especially in high-risk groups.
For general hypertension, diuretics and ACE inhibitors are first line. But for hypertension in diabetic patients, ACE inhibitors or ARBs are strongly preferred.
Because of that renoprotective effect.
Exactly. They preferentially dilate the efferent arteriole, which reduces intraglomerular pressure and slows the progression of diabetic nephropathy.
We have truly mapped the kidney's microailments today. We started at the filter, clarified that core distinction between the inflammatory nephritic syndrome and the leaky nephrotic syndrome.
And we established the diagnostic power of the urine chemistry in triaging AKI. The compensating prerenal kidney retains salt and has a low FeNA, while the damaged intrinsic kidney wastes salt and has a high FeNA.
And don't forget the plumbing issues from E. coli to the urease-producing Proteus that builds those struvite stones.
And the fact that calcium stones are the most common and, weirdly, are sometimes managed with thiazides.
It's just remarkable how specific the damage is, but how widespread the systemic consequences are.
Which brings us to our final thought. We've seen these profound diseases result from the failure of these tiny, highly specific transporters managing common stuff: cysteine, uric acid, sodium. And the fragility of these mechanisms makes you wonder, how many other critical molecules in our body are just one transporter defect or one rogue antibody away from causing systemic failure?
The kidney is the ultimate biochemical balancing act. Its constant calibration reminds us that our bodies are perpetually teetering on this fine biochemical edge.
And when that edge is compromised, the consequences are always systemic and dramatic. Keep that sense of wonder alive as you continue your own deep learning.
Thank you for joining us on this deep dive. Until next time, keep learning, keep questioning, and keep the deep dive going.